So if we're going to talk in Spanish, let's do it. I am a plastic surgeon from Argentina. I'll show you what I do in combination of different treatments on the chin and other areas of the face that we refer to as a perfiloplasty. Just to provide a reminder of what we refer to when we say perfiloplasty is the harmonization of facial structures, not only the chin or the nose, but to be able to harmonize it with the malar and the gonial regions. In the field of plastic surgeon, we follow these planes. Gonzalez Ulloa, you do cephalometry in the rickets plane, which is very easy to be done in your practice with a very simple rule of thumb that would give you the tip of the nose, the tip of the chin, and the lips. They do not have to be in contact. If that is the case, that is a chin retrusion. This is cephalometry from an angle 3, which means that the chin is beyond the maxilla, and the opposite in the angle 2, where you have an inverted bite, where you have a different maxilla regarding a protruded chin. To the left, you see a rickets angle, which is normal, with a separation of 2 to 3 millimeters separation from the upper lip and 1 to 2 millimeters on the lower lip. On the right, I have a negative. There's a high contact of the lips because there is real retrusion of the chin. If you see the patient here, you see he's got a type 2 bite with a retrusion of the mandible. My training on maxillofacial surgeon, what I do is I try to address these cases in the following fashion. When you use the Dal-Pont osteotomy, requires you to have an orthodontist in the team. The surgical procedure has to be determined by that specialist. You have higher risk, higher complications, it's more expensive, and you need to do it in a hospital of high complexity to be able to do it safely. When you do preform or precast silicone implants, we sometimes use them. Also polyethylene precast implants, I do them to the front, backwards. Whatever you need to do, any plastic surgeon can do it in a safe manner. Some of the materials that I use the precast silicone implant, the precast polyethylene, expanded polyethylene. It's important to mention that you could actually replace any bone surface of the face, the gonium, the angle, the orbital rim. All of these prostheses already exist. What's interesting is you have to integrate the tissue that grows in it. If you want to actually remove it, you would have to fracture it. We need this type of osteosynthesis set to be able to apply it. Otherwise, to be able to get a rigid fixation, it's malleable. I can actually cut it with my blade. It's very easy to do it with the scalpel. You have to immerse it in an antibiotic solution because it's got lots of pores, and you have to avoid bacteria from getting in there. What we do here is we're using a drill to be able to perform a rigid fixation. I'm going to show you some cases and results and the way I assess what I am about to do. The problem here, the patient came to our consultation because of his nose, and I told him that that was not the case. We had to do a perfiloplastic program, and we had to do something about his chin. The pre and the post, where obviously we did a rhinoplasty, but what changed his aspect the most was to be able to provide him with a chin implant. Here we had a problem with a real microgenia. Should I do a sliding osteotomy? I thought about risk and benefits, and I came up with a cast implant, which I shaped myself. It was simple with any visible scars. This patient had a real microgenia. What would I do? I talked to the patient. I convinced him of not doing so. I used a rhinoplasty. I came up with a silicone cast. This is the pre and post on a profile aspect. The patient already had a chin implant. It moved, and he wanted to have a more square-looking chin. In this image, you can actually see that there was a dislocation of the prosthesis. Here, you can see that it had actually moved in an obliquous fashion. We took it out and we use a precast polyethylene implant. Here's the before and after of the patient with a square looking chin. The problem here was gonial. He wanted to improve his features. He wanted to look in a more male way, more masculine. So we did a malar fat filler, and what we did is we were able to masculinize his face a bit more. His boyfriend got jealous, and he came to my office to do exactly the same procedure. So I added a chin liposuction. I could not tell him that, and this is the result. Both of them were very happy with the result. As a matter of fact, I liked his result much more than the previous one. The problem is he had very low self-esteem. He thought of himself as being ugly. He was not very pretty, but he was not that ugly. So I had to do a complete makeover of his face. What did I do? Rhinoplasty, precast silicone malar implant, gonial implants, and chin implants. Here you have the before. Look at the before in the profile. We had to implant the gonial one with special retractors, otherwise you cannot get there. Here I was placing the other implants. You can see a very important change in the way he looked. I can actually say he looks handsome. See, it's a handsome boy. In this case, he had a microgenia. He had already been operated on. He wanted to improve his results. We changed his already existing implants, and we added some polyethylene expanded implants plus fat. I used the same incision. Here we had a real microgeny. There was no other result, no other possibility than osteotomy of the chin. I did the rickets cephalometry, which allowed me to calculate how much I would have to take out. This is the before and after. You can actually see it much better here. And as you can see on the image, you can perfectly see how much I took out of the chin, the before and after. Another microgeny. Again, I had to do osteotomy. Here's the my surgical plan, what I intend to do. And this is what I'm doing. This is me performing it. I perform multiple small holes with a drill by previously demarking the area of 1 to 1.5 centimeters. I drill the holes with and I was able to connect it to the bone. I had to make sure I would smooth out the area to avoid any sharp edges that could make the chin look sharp. What was the problem here? This is the typical witch chin. That's how we find it in the literature. They have a high projection of the chin, and it's hollowing before the lip. I took the osteotomy and then I placed it as a graft below the lip, and you can see a very noticeable chain, plus a rhinoplasty. This is my last patient. It's interesting what we had to do. There was a point in time when she came back as an adult. I've been operating for 25 years. And I run across a patient with a hemifascial microsomy. She wanted to improve this great asymmetry. And what I did, I took from one side. I did a bichectomy on one side, a lipo of the cervical area, and on the other side, I did lip grafts, and I repositioned the chin because it was displaced. Here, you see the vector system provides a perfect image in terms of colors and positions of the patient. You see the the profiles. The yellow, it's the volume that we have gained on one side, and the blue is the depression we were achieved with the lipo and the mandible procedure. When you think that when a patient visits you for a chin or a rhinoplasty, offer them a Perfiloplastia to improve the entire facial unit to achieve harmony. On my hands, it is a compliment when they come asking for a rhinoplasty. I try to orient them around the concept of harmonization. Take into consideration the ricket plane. With a ruler in your office, you can determine whether they are good patients. I also order extra. I also check if their bite has any problems to make a decision whether they'll need a osteotomy. Feel familiar with all kinds of material, not only fat. Think about the precasts. It's a very important therapeutical branch and tool for plastic surgeons on the day-to-day basis. Thank you so much for your attention.
Excelente, muito lindos os seus resultados.